Good morning, Dr. Phibbs. Are you able to see me?
I am.
Hi, how are you? So
I'm
we are
good, thank you.
okay. It's been like pouring here. So there are some folks
Ah,
who joined already, but we are waiting for others to join. The
okay.
weather is very, it's like I could show you. It's just very like, so we have everything. I don't know if you can even see it. So there are five, six folks here, but we are still waiting.
Okay.
Um, so otherwise we are good to go technologically, right? Sort of. So this
Yeah,
is okay.
good. I just wanted to make sure that I was at the right site,
Yes,
at the
and
right Zoom link. Good.
I think you are only the presenter joining from Zoom, so we
Okay.
didn't make the link available to participants because this was in-person meeting.
Okay. Gotcha.
So that's why you wouldn't see anybody else. But I hope people would be able to make it. It's just very. I think for people to drive, it's not a good day. That in Minnesota,
Yeah,
it's just bad today. Yeah, and
no
then
problem. So will
okay. So I will.
and I'm in no hurry, so I've got plenty of time. I don't have anything after this, so we're good.
Okay, perfect. Thank you, Dr.
Yeah.
Phibbs. And then I didn't say bye to you yesterday, but I hope you liked the presentation.
Oh, you did a great job. I thought that was fabulous.
And I took a lot of resources from Seal America and also from ACTDD. So I mixed up
Uh-huh.
everything. Yeah. So okay, and then I'll follow up with you after this forum to just to debrief and see how we can, like do that training
Yeah.
again in the future. So okay,
So
Dr. Phibbs.
the people that
Um,
are there, are they mostly the sealant folks? Any school nurses
yes.
there?
Yeah, so right now we have dental hygienists and then more like programs who are doing the work. So they may not be
Okay.
providers, but they are more in the grant management space or more like project managers kind of. So
Okay.
we have I think 20 different programs have signed up to come in.
Hmm.
So we are hoping that there'll be 20 folks and there's panel discussions and other things after a few hours. So I don't know when folks would arrive because we said we'll start at 9:30, so they should still be coming.
Yeah.
Okay. Okay,
So
Doctor.
yeah, so just let me know. I will be here. If I don't respond right away, I've just stepped out to get another cup of
Okay.
coffee or something.
Okay. 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 Thank you, Dr.
Okay,
Phibbs. Bye.
sure.
Dr. Phibbs, are you able to hear me?
I can hear you.
Yes, we have around 10, 12 folks who have joined already, and some of
Okay.
them are joining through Zoom. So andOral is going to start. So I'm just giving you a heads up that we'll start in about a couple of minutes.
Okay. Then
Okay.
I'm going to go ahead and click the share my screen
Yeah,
link
try
so that we
sharing
can get
your
that.
screen. Yep. And I'll tell you if you can see it. So can you project Dr. Phibbs there and then we can start?
Oh yeah, where's the Zoom? You just
Yeah, let me see here. I need to go to slideshow. Beginning.
Dr. Phibbs,
Okay.
andOral is saying hi to you. Hi.
Hello. Nice to meet you.
nice to meet you
Zambia,
too.
Zambia
I
farm.
wanted to let you know my parents are actually starting a farm in Chipata right now.
Oh, are they? Fabulous.
So
That's fabulous.
yes, if you want, can we set up a meeting? Because I'd like to meet you more officially, and I want to tell you about my farm.
Yeah, absolutely.
Oh, one thing, you have to change the sound settings. So
Okay.
perfect. That's here. That's here.
andOral has some coffee. No?
Me?
Yeah.
I don't know why the
your
output is
water.
not doing this.
Yeah, just make it louder. Otherwise, we'll just do the microphone.
Where's the Zoom? Oh, you're using Teams or where's Zoom?
I love in Zoom.
Oh, here, let me control the mouse real quick.
Well, I will.
Why can't it do it? Yeah, if you could go to the Zoom, I don't know why the audio is not going to this thing.
Crystal is unable to.
Hello, how are you? I made it. It's been kind of rain. It was so bad.
It's done. We got this. We got it. No accidents. So, in my truck, I'm like, it's a tutorial for
andOral, can you stop the sharing there?
Yeah, I was definitely like, I don't want to hear it.
Hi, nice to meet you.
Yes, have you?
Yeah, Julie.
Nice to meet you, Prashida. Do you want to grab some coffee?
Oh, you did too.
Can you just stop sharing this thing there? I can pull it back for some reason.
Yeah.
Just
I wanted it too, but not until I was like starting to drive. I'm like, we should have driven there. I just assumed that,
okay. Then now you want me to show you the. You want me to show you the.
For a long time. We did listen in on like that critical part.
You want me to do that? Show you the Zoom, right? Like I logged in using the.
Here?
Yeah, open that. Can you see it? Or is
Sorry,
it like
this one?
no? I opened that. Can I show you the Zoom?
Yeah.
Because I opened that. See, this is Zoom. So Dr. Phibbs is already sharing the screen.
And then turn on.
Dr. Phibbs, do you want to try speaking? I can see if we can hear you.
So how is this?
This is pretty good. Right? Give me 1 second. Is it like yeah?
Oh, I know what you mean, like the truths that are right, like you come down the S curves and it's right on the right. So we're just a little bit down at 45, you turn right on there. And then we're kind of like.
Dr. Phibbs, do you mind talking again?
Absolutely. So can you hear me well enough?
I think this is already good enough. Is this
Okay.
orange? Yes, one more time, Dr. Phibbs. Sorry.
Oh, no problem. So can you hear me now? This is a test.
Yes. Yes. So we can put you on the screen now. So, and Declan, I need your help here now. I need this to be on the screen so we can start.
So just let me know when you are ready for me to start.
Yes, but I think Dr. Phibbs, my computer is giving. I think just don't worry about the microphone. We'll just use my laptop. That is working well.
Okay, so once you are ready for me to go, just you'll need to unmute yourself and let me know that you are ready for me to start, and then I will proceed.
I think I got it.
Okay.
Okay.
How can we do this full screen though? I normally use the app just because. Do you
I
have
think
the app?
this is okay. This is easy. Dr. Phibbs, we are ready. Are you able to hear us now?
Yes, I can.
Okay.
So can you, am I loud enough? I can actually increase my volume on my end if need be.
I think we can hear you pretty good enough right now.
And then I'm gonna face it.
Okay.
This way so that the sound goes out.
Okay.
Perfect.
And did you want to start?
I can go ahead and start this.
Turn on the video for Dr. Phibbs. Give me 1 second.
Hello, everybody. You all know me? Okay. So hello, everybody. But hello, my name is Nicola Sakala. I also go by Paula because both of them today I consider them my best friend. I'm taking the first one. And so I just wanted to say thank you so much for all being here. I know it's kind of raining cats and dogs outside, but I'm just really happy to have you. And so this is going to be ideally the way I like to do meetings like this. It's just kind of collaborative in the sense that if y'all have questions, we'd totally be happy to answer any for you. Or if you want to speak to any of the presenters, then we can also do that. And so, yeah, I think we can go ahead and get started. Our keynote speaker is going to be Dr. Phibbs. She's been a really good associate with us. She's done a lot of work in terms of how we can collaborate with school nurses, and also our basic screening survey that we do every, I think, 5 years. And so, yeah, she's been really great. And so I will let her also introduce herself.
Okay, so I'm assuming that you are ready for me to get started here.
Yes, Dr. Phibbs.
Okay, so I want to welcome everybody, and my apologies for having a few little technical difficulties here, but that's what happens when the meeting's in Minnesota and I actually live in California. So I'm going to be talking today a little bit about collaborating with school nurses in order to improve the oral health of Minnesota's children. I don't actually have a camera on my computer, so you won't see me, but I thought it might actually be a good idea. Let me do this. I need to close something here and move forward. There we go. Okay, so that you can actually see me. So I'm the person on the right-hand side. This was taken, just a couple of weeks ago at Volcanoes National Park in Rwanda. Also went to Zambia on this particular trip for 3 weeks. And we actually were in Rwanda because my husband and I are both wildlife photographers. So these are a couple of photos that we actually took of the mountain gorillas in Volcanoes National Park in Rwanda. So that's a little bit about me. I am got my training as a dental hygienist back in the dark ages and actually in the 1970s, and then have a master's in public health and a doctorate in public health in epidemiology. So I want to start off talking a little bit about facts about schools and school nurses. The American Academy of Pediatrics recommends that you actually have one full-time school nurse per school. And the Centers for Disease Control recommends that we actually also have one school nurse for every 750 students. So if a school is larger than 750 students total, they would need to have more than one full-time nurse. So that's the recommendations. The reality is that there's actually a school nurse shortage. And in the United States, about 40% of schools do not have a full-time school nurse, and 25% of schools do not have a school nurse at all. And that's from the Journal of School Nursing from 2018. Now, COVID has made it so there's actually even more of a school nursing shortage. So there are probably more than 25% of schools right now that do not have a school nurse. So the shortage is well known. This is actually from the University of Washington, their School of Nursing. And in the state of Washington, there's about one nurse for every 1,173 students on average. Now that is a school nurse to student ratio that doesn't take into account that many schools now have many more children that actually have some sort of a health issue. So there's many more children in school than there used to be that actually have some sort of a disability, because we now have all of those children entering into the public school system where 20 years ago they were not in the public school system. So if you look at school nurses, traditional public schools are more likely to have a school nurse compared to charter schools. So about 84% of traditional public schools have a school nurse, either part-time or full-time, versus about 52% of charter schools. Surprisingly, higher income schools are more likely to have a school nurse compared to lower income schools. So if there are less than 25% of the children in the school that are eligible for free and reduced lunch, 87% of those schools have a school nurse, versus less than 80% of schools that have more than 75% free and reduced lunch are likely to have a full or a part-time school nurse. The other thing is that urban schools are more likely to have a school nurse compared to rural schools. So if you look at current Minnesota laws, Minnesota requires that a licensed school nurse be an RN with a bachelor's degree or higher in public, and then also have a public health certification or licensure. So not only do they need to be a nurse, but they need to have that degree, and they need to have a separate public health certification or licensure. Now, a Minnesota law currently that was passed in 1986 only requires a licensed school nurse in a school district if there are 1,000 or more students. So that means that if a school district only has 999 students, they don't need to have a school nurse. It also means that you only need to have one school nurse. So a district that has 39,000, 40,000 children only needs, by Minnesota law, to have one school nurse. And the school nurse organization of Minnesota estimates that only about 1/3 of Minnesota schools actually have a licensed school nurse. So the majority of Minnesota schools don't have a school nurse. Now, there is legislation that has been submitted to actually increase the requirement to have a school nurse in the state of Minnesota. So the school nurses are very important. And we actually have a National School Nurse Day, which is for 2024 is going to be May 8th. And so that's one of the things that in working with school nurses, to just recognize them on a National School Nurse Day. May 8th is a Wednesday. National School Nurse Week is that entire week surrounding May 8th. But May 8th is going to be National School Nurse Day. So we all know that oral health impacts learning. So when children's oral health suffers, so does their ability to learn. And when you are working with schools, school districts, school nurses, and making them realize the importance of having an oral health program, this is some information that you can actually use to hopefully encourage them to have some sort of an oral health program. So we know that children with toothaches in the last 6 months are 6 times more likely to miss school, and they are 4 times more likely to have a low grade point average. We also know that when oral health problems are treated, school attendance actually improves. So that is research that is out there. If you need to have the reference, I would be happy to share that with you. We also know that there is a cost of missed school days. And in the state of California, we actually estimate that missed school days because of dental problems results in school districts losing about $29 million each year in what is called average daily attendance funding. So schools actually receive funding based on the number of students that are actually there on a daily basis. And by that time away from school because of dental problems, it is estimated that schools lose a large amount of money because of those missed school days. So the more we can keep children in school, the more money those schools are actually going to get. And so this is another reason to really encourage schools to identify oral health problems so that children don't miss school. So we know that if we improve oral health, we're actually going to improve learning. And if our goal is to improve oral health, we need to actually learn a little bit from the past. So I want to tell you a story, and this is a story that you can actually tell also to schools and school nurses to encourage them to have some sort of an oral health program. And the story I want to tell you is actually a tale of 2 different generations. Generation number one are the baby boomers that were born between 1949 and 1958. So that includes me. And actually, the photo on the right is a photo of me when I was 3 years old in 1958 on the beach in California. So even though I'm originally from Oregon, I was actually destined to be a California girl. So let's look at what the oral health was of those baby boomers in 1966 to 1970. And this is a US oral health survey, a national survey that was conducted between 1966 and 1970. So this is the oral health of those children that were born between 1949 to 1958 when they were 12 to 17 years of age. And this is showing the number of permanent teeth with a history of decay. So 10% of those children born between 1949 and 1958 were caries-free. 32% had 1 to 4 teeth with a history of decay, and 58% had 5 or more teeth with a history of decay. I fall in the 5 or more teeth. So every single one of my molars and a couple of my premolars have restorations. Either a 1 or 2 surface restoration when I was a kid. Now they're all crowns because of fractures associated with the restorations I had previously. So almost 60% of children that age had 5 or more teeth, had severe decay. So things have happened since World War II in the United States, and it's really important to understand what has happened since World War II. It was a significant impact on the United States and actually other countries as well. There were tremendous economic and social changes. There was a higher standard of living, more universal education. So in 1950, fewer than 40% of US adults had a high school diploma. Now, my father, who was born in 1914, left school in the 8th grade. So there was a huge proportion of the population that did not have a high school diploma. We have improved housing. So in 1950, 36% of homes in the United States did not have indoor plumbing. The house that I was raised in, we did not have full indoor plumbing in our house until 1960, when we actually left the farmhouse that I was born in and moved into a newer home on the same property. That was even in rural areas, more homes actually lacked plumbing. So in 1965 is when Medicare and Medicaid came about. So tremendous economic and social changes after World War II. We also had urbanization and unionization. And I'm going to talk a little bit more about the importance of unionization in a bit. So there are also some other things, and these have to do with oral health specific changes. Water fluoridation came about in the 1950s and the 1960s. Fluoride toothpaste came out in the 1960s. And other topical fluorides also came out in the 1960s. And I have an older sister who is actually enrolled in the fluoride gel research projects that occurred in the 1960s. More oral health specific changes include higher quality dentistry, pain-free dentistry. Local anesthetics didn't come about until the 1960s. I had local anesthetics when I was a kid, but my sisters who are older than I am did not. And they to this day hate going to the dentist because they had most of their dentistry done when they were kids without local anesthetics. We also have increased access to care, And that came about in 1954 with the first employee dental insurance plan. And that had to do with the unionization of the longshoremen and warehousemen's union in Oregon, Washington, and California. So the longshoremen's union, instead of taking a pay increase in 1954, agreed to have employee dental insurance for all of their children. Now, I was born in 1955. My father was a longshoreman, and so I was the first generation of children to actually be raised with dental insurance. Then Medicaid came about with dental insurance in some states for children in 1965. So let's move on to generation number 2, which are the echo boomers. These are the children that were born between 1982 and 1988, and they are the children of the baby boomers, which is why they're called echo boomers. Let's move forward to 1999, 2000, and look at the oral health of those echo boomers. So this is the U.S. Oral Health Survey conducted in 1999 to 2000. And this is children born between 1982 and 1988 when they were 12 to 17 years of age. And you can see that now in this generation, 44% of children had no history of decay on permanent teeth, and only 13% had 5 or more teeth with a history of decay. So between the baby boomer generation and the echo boomer generation, one generation, we had a significant reduction in the percentage of our population that had severe tooth decay. It went from 58% of the population down to 13% of the population, mostly due to all of those transitions that I talked about in economics and also fluorides and changes of dentistry. So we had a severe reduction. But who are those 13% of kids that still remain at risk for tooth decay? Those are low-income children, racial and ethnic minorities, and realize that the racial and ethnic minority population probably has increased rates of tooth decay because they are more likely to be low income. Children that are eligible for free and reduced lunch are 3 times more likely to have severe tooth decay. So that's data from multiple different states. So we know that low-income children are the ones that are more likely to have severe tooth decay. We also know that 32% of children living in the state of Minnesota are eligible for the free and reduced lunch program. And that it varies by county. And that if you actually look at McLeod County, 67% of children living in that county are eligible for free and reduced lunch. So if you look at the state of Minnesota, this is the percentage of children receiving free and reduced lunch by county, and this is from 2021. So you can see that the very dark areas are the counties with the highest percentage. More than 40% are eligible for free and reduced lunch, so that you can see that there are large sections of Minnesota where there are a lot of low-income children. Now, I am not that familiar with the geography of the state of Minnesota, but I'm assuming that this big area up here are the rural counties, I'm assuming. So let's talk about kind of the elephant in the room, and that's COVID-19. So many children in the state of, actually throughout the US, are still not going to the dentist. And that we know that the number of children with dental problems has increased because of COVID-19. We also know that school dental assessments are the best way to identify those in need of care. So a little side story. I have a private practice dentist that I've been going to for 20 plus years. This particular dentist books 1 year out for my annual cleaning. And I had an annual cleaning that was scheduled in June. And in April, I realized that I had a work conflict. So I called in April to change my June appointment and wasn't able to get in for an appointment until yesterday. So I went in, had my cleaning yesterday. So in April, I called and I wasn't able to get in until September. Well, for a low-income family that may be relatively mobile, that may have a problem, getting into the dentist is still difficult because of backlog of exams due to COVID, but also because there are fewer clinicians actually providing care. And getting into the dentist is even worse if you're actually relying on those safety net clinics. So it is still having an impact because of COVID-19. So in working with schools and school nurses, having a dental assessment is very important. And the National Association of School Nurses recommends that all schools have some sort of dental assessment. And they actually have 3 different recommendations for how to conduct a dental assessment. The first is child behavior or asking the child questions. The second option is doing screenings with a school nurse, so having the school nurse do screenings. The third option is doing school-based screenings and having a dental professional do those screenings. So they're giving schools and school nurses 3 different ways in which they can actually do some sort of a dental assessment to make sure that children in need of care actually can get a referral into care. So the child behaviors are questions that a school nurse could look at, and teachers, administrators, is behaviors, whether or not they're flinching while they're eating, whether they're holding face, avoiding smiles, or whether or not they have chronic ear infections. Some of the questions that they can ask is, do you have a toothache or teeth that hurt? Do you have teeth that hurt when you eat? And do you have teeth that wake you up at night? So if there is not a way to do an in-mouth screening, either by a nurse or a dental professional, this is something that a school could potentially do. It's better than nothing. And if a child actually reports pain, that the school do some sort of a referral. The problem is, the downside to using questions is we all know that some children do not have the ability to verbalize oral pain, or they may have an abscess that's actually not painful. So although asking questions and looking at behaviors is better than nothing, it actually has substantial problems because you may not actually recognize all of the issues. And if a child has had grown up since they were 3 having a bombed out molar, when they're in 3rd grade, that bombed out molar may actually just still not be hurting them anymore. So then, in talking to schools and school nurses, really doing an oral health screening is substantially better. Making schools realize that these oral health screenings are simple, quick, they're non-invasive. They can be done by a school nurse. Using a flashlight to look for obvious signs of disease, it takes less than a minute, but we always encourage schools that if school policy allows, that the school nurse ask a local dentist or hygienist or one of the school-based oral health programs to actually do the screenings for them. Now, in some cases, that just isn't possible. So to let you know, for one example is that the Los Angeles Unified School District, which is the 2nd largest school district in the United States, the only school district that is larger is New York City. For many years, they did not allow outside providers into the schools because of a school lockdown policy that they had. So they could not actually have local dentists or hygienists volunteer to come in and do the screenings. So I went down and actually did a screening, both a didactic and a hands-on screening for the school nurses, trained them how to actually identify oral health problems. I will tell you that the school nurses loved the training because nobody had actually ever taught them how to identify oral health problems. So if nothing else, if you can't get into the schools, that actually working with the school nurses and providing some sort of training for those school nurses is actually a very good option to do. It's going to benefit the children if for some reason you can't get into the schools. Now, if you decide to make the decision to train school nurses, there are a couple of things that you actually need to tell them because they're just not familiar with it. And that is really that there are 20 baby teeth. Knowing what the eruption pattern is very useful for the school nurses because once again, they've never been taught this. So the primary teeth and the permanent teeth. And to encourage them to really realize that those primary molars start to erupt when a child is about 6 years of age. They will erupt earlier in certain minority populations. So American Indian, Alaska Native children actually erupt earlier than white non-Hispanic children. And Black African American children also tend to erupt their teeth earlier than white children do. The other thing to realize is that we quite often go into schools and do screenings when a child is in 2nd grade to look at their molars. But the age of enrollment for children into kindergarten has increased over the last 20 years. And more children are actually starting kindergarten when they are late 5 or actually even 6 years of age. And that a child that has English is not their primary language may actually not enroll into kindergarten until they are 6 years of age. So we have more and more kindergartners that actually have permanent teeth. The thing to let school nurses realize is that decay in permanent molars really needs to be treated as soon as possible because of those teeth that they are erupting in kindergarten through 2nd grade, those teeth need to last them a lifetime. So in working with school nurses, what they need to realize is that there are really 2 oral health screening questions that determine when a child needs to be referred to care. Does the child have tooth decay, an abscess, or a broken filling? If yes, how soon should that child see the dentist? So what we tell school nurses is look for obvious problems. Are there holes in the teeth? Are there broken or missing fillings? Are there signs of an infection or an abscess? In school nurse language, often called a gum boil. So if there are no obvious problems, encourage them to have regular dental visits. As dental professionals, we all know that. If there's early dental care, they need to be within the dentist within the next few weeks. And if that child happens to have pain or infection, we need to get them an urgent referral to care. So this is what teachers and school nurses need to understand is how soon should that child actually go to the dentist, and really encouraging them to focus in on those kids that have pain or infection, that those are the children that they should focus on first, then follow up by those children that need early dental care. So a sample screening results letter that you can use. I think all of you have seen this in the programs that you're actually working with. Since I'm talking to a group of dental professionals, you all know the OSHA recommended infection control, but a school nurse may not actually know that. So it's talking to them about if they are going to be doing screenings, what type of infection control should they actually be using. making them realize that good lighting is essential and what their lighting options are if they're going to be doing the screenings themselves. The one thing that I found in doing a school nurse training and working with school nurses is one of the things that they do not understand is actually how to hold a light. And I was actually quite surprised is when I handed a school nurse a light to actually do an oral screening, that they would all grab it like a hammer rather than like a pin. And they had very difficult time controlling the light because of actually how they were holding that light. So one of the first things I do in working with school nurses, if I'm training them on how to do an oral health screening, is to make them realize that they have much more flexibility if they use a pin grip, because it provides a better range of motion. Telling them that they can use tongue blades if they wish to get the tongue out of the blade way or to pull the back, and then also talking to them about screening ergonomics, because once again, they've never really spent much time looking in children's mouths. They don't as necessarily understand the screening ergonomics. Letting them know that the child can sit or stand, it's probably faster if the child stands, that the screener can stand or sit. The other thing is to teach them what it actually tooth decay looks like. So as dental professionals, this is just a piece of cake. It's, understanding to us, but they don't necessarily know what a cavity looks like. So focusing in on holes in the teeth, that they're brown in color, that they can be black, they can be whitish, they can be yellow, to really show them photos of what tooth decay looks like. Some more examples, and I will share, if you ever want to do a screening with nurses, I will be happy to share this presentation with you that you could use. So some more examples, as we start using silver diamine fluoride more often, it's for nurses to understand what SDF is, and then also what it looks like, so that they can know what it looks like. Some more examples for them to understand. So really focusing in on with nurses, getting them to realize what tooth decay actually looks like. The more examples that you can share, and then some of the smaller cavities. Now, nurses this is where they have a difficult time, is really looking at those smaller cavities and understanding, realizing that it is actually a cavity. For them to realize what a broken filling is and what a missing crown looks like, what broken fillings are, having them realize what fractured teeth look like, what an abscess looks like. So this is something that they may never have seen, that they may actually have never lifted the lip up to actually see what an abscess looks like. Once they actually see this, they'll understand, because they're used to dealing with abscesses in other parts of the body. And making them realize that they need to look at the gum above and below the teeth on the cheek sides. That, abscesses on the tongue side are relatively rare. Looking on the cheek side, so helping them understand what they actually need to be looking for, something that comes second nature to us. Then sharing with them a dental screening flowchart that actually makes them realize when they need to focus in on getting that child urgent dental care. The other thing is making them understand the conditions that don't require referral. Things that we see all the time as dental professionals that we know is not disease, they may not necessarily know that it's not disease. And some of the conditions that I found that they really have a difficult time understanding are all of these developmental defects. There's something that they're not used to seeing, that they need to understand that it's not disease, that it is a developmental defect. Letting them know what a crown, different kinds of crowns and fillings look like. Talking to them about injured teeth. Now, if a tooth is injured at school, they need to refer that right away. But to make them realize that there are other injuries that they may not have seen before. Letting them know what a dental sealant looks like. Letting them know what space maintainers are so that they can understand. Just showing them different options. Supernumerary teeth. They may never have seen supernumerary teeth before. And then sharing with them a wide variety of different resources that they probably don't know exist. And these are national resources. So the National Association of School Nurses has considerations for school nurses in return to school for dental screenings. This was actually done as part of the COVID-19 response when schools went back. And it was developed by the Association of State and Territorial Dental Directors in collaboration with the National Association of School Nurses. So this is a resource that you can actually share with them. There's also this oral health screening pocket guide for school nurses that was created by the Ohio Department of Health. So this is a very nice little pocket guide that they can download and print. It was actually created back in 2007, but it's still relevant today. There's also some dental trauma decision trees, which are very good for school nurses and actually anybody. That is, if there is a trauma, what actually should be done as far as seeking care for that trauma. So this is something that's very good for school nurses, school administrators to actually have on hand for them to refer to. So they, if a child is out on the playground and knocks out their front teeth, what front tooth, what do they actually should be doing? There is also a dental health guide for school nurses that was done by the state of Missouri to help them realize what kind of dental first aid supplies they should actually have in the school, and actually how to deal with dental trauma also. So this is another good guide to have on hand. But the other thing that schools want to do, and the thing that I hear all the time from schools, is that, yeah, if we do a screening, how do we actually make a referral? We're not doing doing school screenings because we don't actually know what to do with that child if we identify a problem. So working with them, if you are not actually doing the referral yourself, on how they can make effective referrals for their students. And getting them to realize that children needing urgent care are always the priority, that they need to contact the parent, find out if they have a family dentist, that need to understand that dental care delivery system can be extremely difficult to navigate, and they may actually need to assist the parents. That is especially helpful if the parent has low literacy level, has difficulty speaking English, and needs to have a referral. So the nurse may need to provide some sort of assistance if they have no one else providing that assistance for them. The key to successful referrals for a school and a school nurse is to develop a personal relationship with the dental clinics that serve their schools. Arranging a time to meet with the dental clinic staff, the dentist and the front office staff. And I say that having the front office staff is very important because I have worked with dentists that said, yes, if that school comes up with an urgent referral, we will take that child. We will do no cost care if the child needs needs assistance and they don't have any type of insurance. But when the parent or the school nurse calls the front office staff, if the dentist hasn't communicated to that front office staff may not necessarily make an appointment. So develop a referral system between the school and those dental CLAPAs that may include a call, a text, an email with the clinic, telling the parent to call the clinic and tell the staff it's the referral from the school nurse, creating a referral sheet for the parent with the clinic phone number and how to make the appointment. So I want to give you a successful example. And this happens to come from the county that I live in, which is San Luis Obispo County in California. It is a cooperative effort between the dental society, school nurses, and the health department. So for many, many years, the local dental society in our county has, as a public service, done dental screenings in K through 5th grade for every school in the county. So the local dentists screen the schools and they identify children needing urgent care. The local dentists and our federally qualified health centers have agreed to provide care to any child needing urgent care, regardless of their ability to pay. The parent is given a referral sheet with information on how to make an appointment, and the school nurse doesn't do any of the screenings, but the school nurses are the ones that are actually providing the follow-up to assure that those children identified as needing urgent dental care are actually getting into the dental offices and getting their care. And I will have to say, this cooperative effort had a few hiccups to start with, but I will say that it is being extremely successful, and that the number of children needing urgent dental care over the years has decreased substantially. And it's generally now only children that have recently entered the county school districts that are actually being identified as needing urgent dental care. So a very successful program. So the Minnesota Oral Health Program does have some future activities working on this. They are continuing collaborating with the Minnesota School Health Consultant, and they are hope to provide annual school nurse trainings. We provided one and will continue to provide. And they hope to convene a community of practice learning collaboration for school nurses to learn about the oral health needs in schools and opportunities they may actually have for partnership. So that is the end of my session, and my apologies for a few of the technical glitches that we've had. Hopefully I will have provided you with some information that was useful. So any questions, anything that I can actually help you with, I would be happy to.
Thank you, Dr. Quigs. Sorry, thank you, Dr. Phibbs. I was mixed up. So I will pass the microphone to Andy, and maybe you can see if there are questions. I learned a lot.
I think so. One question I have is how can also dental professionals work to navigate with how can dental professionals reach school nurses in order for them to be able to form those collaborations? Because I know you had mentioned Minnesota has a real shortage in school nurses, and when we spoke with our partner at MDH, Denise, she had mentioned that school nurses are also very, very overloaded with taking care of so many kids for so many districts. And so how can we on the dental side be able to, you know, support with those efforts?
I think one of the things that you can do is to be able to offer screenings to schools and assist with that referral process to reduce the amount of work that they actually have. Yes, and to make them realize that by allowing somebody to come in and do the assessments and help with the referrals, that it may increase what they need to do in the short term, but it will decrease the amount of time that they need to spend in the long term. And I think that Denise will actually be very helpful in navigating that first step to make them realize that it will be useful for the school and for the school nurse.
I have a question for Dr. Phibbs.
And what's your question?
So, many times we hear that nurses don't have oral health screening as part of their contract. And even though we have some funding to do the work, there is contractual issues. And I did speak with Dr. Phibbs about it, and she had great insight about it. So maybe can you ask Dr. Phibbs, were you able to hear my question?
Not very well. Could you repeat it?
Okay, maybe I'll do it from there.
Or we can just do it as a HowTheir with
We muted ourselves here. So Colin, can you?
Yeah, it's unmuted.
It's unmuted now. Dr. Phibbs, are you able to hear me?
Yes, I am.
Okay, so you and I were having conversation about how nurses may not have oral health screening as part of their contracts, and sometimes that could be a structural barrier. And then you had a great insight about how to approach that problem. So I wanted to make sure that others heard your solution to the contractual issues with scope of practice and other things.
Okay. So when it comes to oral health screening per se not being in a contract, school nurses are responsible for the overall health of the child. That if there is an infection anywhere in the body, that they are actually responsible for that, and to make sure that they understand that oral health is just part of the body, that they're not separating it out, that they are responsible for the overall well-being of those particular children in those schools. So even though oral health screening may not necessarily be in their contract, an oral looking into a child's mouth is part of an overall physical examination. That if they are concerned about the overall health of the child, they shouldn't just be skipping over looking in the child's mouth. And as dental professionals, we realize that that's important. But I think many health providers kind of separate the mouth, saying, oh, that's dentist's responsibility, not my responsibility. When in fact, if they went to a pediatrician's office, the nurse doing an assessment would actually ask the child to open their mouth, and they would look in the child's mouth also.
Mm-hmm. Thank you, Dr. Phibbs.
Did anybody else have any questions that I can just echo them? Yeah.
Is she going to send the presentation to you guys and then we'll look at it?
Yes.
Yes.
So we will be forwarding this entire presentation out to everybody, similar to what we're doing tomorrow as a PDF.
Sorry, she was talking about the presentation that she gives to school nurses.
Okay, yeah. So Dr. Phibbs, would you actually be able to send us the presentation of school nurses, or could we
Yeah,
even
be happy
invite you
to.
to maybe a meeting or collaborative practice so that people can also see that meeting? Sorry, with school nurses where they can also ask questions about your presentation and learn from that as well?
Absolutely, be happy to share that.
Yes. And then just quick comment to that, Dr. Phibbs. So Dr. Phibbs and I were able to deliver training to school nurses through Denise. So we had an office hour and we had very good participation. So we did create slides to train the school nurses. And after today's presentation, what I'm thinking is I can follow up with Dr. Phibbs and see if we can do like a handout. It's more like a clinical practice tool or something. So everybody's using the same thing. So if you can give us just, Dr. Phibbs,
And-
what do you think about that?
I think it's a great idea. And what I would suggest is that I share the slides that the original slides with you, and that maybe you take that and stamp it with the Minnesota Department of Health branding. So that when you are using it, that it's coming out of the Minnesota Department of Health, that may actually go over better with the school nurses if they know it's coming out of the Department of Health.
Yeah, and then we can also do an accompanying clinical practice tool, so there could be some additional information. So if
Yes.
you could give us, if you could give us some time. I think Antekla, you have a community of practice, so we can bring back Dr. Phibbs and talk about the package at that meeting and share it with everybody. And we'll follow up with you, Dr. Phibbs, for to continue the conversation about the materials and our future direction.
Yeah, be happy to.
Okay. Anything else, Antekla, from your side?
Does anybody else have any questions?
Yes.
My question is, in the early part of your presentation, you mentioned that only about 1/3 of schools in Minnesota have a school nurse. Now, if the school doesn't have a school nurse, is there any other point of contact or individual that one could interact with on these issues?
Yeah, so if a school doesn't have a school nurse, they will generally have what's called a health aide. So that is somebody that's kind of designated to be the person to clean the cuts up and put on Band-Aids and such. So I would suggest that health aide might be the next person if they don't actually have a school nurse. One of the other things is I would encourage everybody to also is to really have try to develop a working relationship, at least with maybe from the state staff, with the Minnesota Association of School Nurses, to help them advocate for the legislation that they are moving towards to increase the number of school nurses, to make sure that the law that was passed in the 1980s saying 1 per every 1,000 actually is increased so that they can actually get more nurses into more schools. Because I think that would benefit everybody, the health of the children, definitely.
There we go. And I completely agree with that. Because one thing that we actually talked about with the Minnesota Department of Education recently is the fact that schools can actually bill out for doing oral assessments. And so I think they can also do sealants as well. The big issue is they don't have the same type of billing system that a lot of clinics are able to have, and they don't exactly have the funding to be able to easily do that. They have an easier time doing it with mental health because if children are on an IEP, there's a different system for them. But with regards to like Medicaid and being able to place sealants, right now they can be reimbursed. It's just a whole process, and it's too expensive for schools to actually be able to buy into it easily. So I think that's another point of like interest where it's like we can do legislation to help support school nurses and being able to actually be billed for their services, so those funds can go back to the schools as well, and also be able to get just more school nurses.
Yeah, we definitely need more school nurses.
I know Medicaid does not reimburse for dental assistants or dental hygienists, licensed professional dental hygienists. So what billing code can school nurses do to get reimbursed?
And how reimbursed for, you're asking about reimbursement for nurses?
Well, if school nurses are if they're getting reimbursement for dental assessments, but collaborative license
Dental hygienists do not.
Yeah.
And we're actually oral health providers. What are the nurses getting reimbursed, whereas the dental professionals are not?
I can ask that question to Dr. Linda as well, since she's the policy person at DHS. And then that way I can better answer from you all. And also ask the same people at MDE, because that's something they're really interested in.
Yeah.
It's just
But I don't think, Holly, right now we have that provision that provides reimbursement for assessment, because we've been trying that for our dental hygienists and that has not been approved. So maybe, so I don't think it's for dental specifically, otherwise we would know.
Yeah, because we keep to write those off every single kid we do.
Yes. And Claire, you would remember all the conversations and
Everything so, which I don't think we have.
maybe that's
I don't believe that third party billing within schools
includes any oral health.
Oh, it doesn't know. Okay, MDE mentioned it, but I can get more information about that.
Yeah, we don't get reimbursed at all. So I was like, oh, is there a different code we should be using?
Yes, I'll get you more of that information in a more clear format too. That's at like clinical. And then I can also send that out once I send all the PowerPoints out.
Okay, thank you.
Thank you. And then
Questions?
awesome. And so what we can go ahead and do right now is Dr. Phibbs, thank you so much for being here and teaching, I know especially me, so much about Minnesota's oral health landscape with regard to school nurses. And now we have Sarah Wolfcha from CDS, Children's Dental Services, and she'll be doing a presentation too on how they got started and, you know, their unique situation as well. And so Sarah, I'll go ahead and give it to you.
And I'm going to stop sharing.
Thank you, everybody. Good morning. And thank you so much for accommodating me remotely. I'm sick this morning, so I'm going to croak at you a little bit, but at least I won't be coughing on you. Let me get my, let's see. Right. Everybody, are we seeing my slideshow?
Sarah, you could do the full screen. Right now we can see multiple slides. So maybe you can do the full slide. Yeah.
There. Okay. How's that?
Yes, that's perfect now.
Okay, great. Well, good morning, everyone. Really great to be with you today. I'm going to tell you a little about Children's Dental Services. To start with, we are a very old nonprofit. We've been delivering dental care in Minnesota since 1919. We were actually established in the wake of the Spanish flu pandemic by a group of charitable women who recognized there was no safety net when about 20% of Minnesota children are orphaned at that time, and feels like we've come full circle and are just as relevant today as we were when we started 104 years ago. These are photos of the early days of care that we did. We were co-located with the city of Minneapolis from 1954 through 1997. And during our time with the city, we became the first on-site Head Start provider in the nation. We pioneered the use of dental sealants on low-income kids at a time when medical assistance didn't cover that procedure. And we've been providing critical care since 1950, again, hailing back from our collaboration with the city of Minneapolis and Minneapolis school-based health centers. We like to think outside of the box about what we can all be doing, and I'm sure so many in the audience are the same, embracing cutting edge protocols for expanding care, like using advanced dental therapists, using telehealth, etc. So this, just a little historical perspective. I think a picture says 1,000 words, but this is our home with the city of Minneapolis for years. We are a very large and robust school-based service provider now. During our time with the city of Minneapolis, we were only in the Minneapolis schools. However, for the past 20 years, we've expanded to schools all across Minnesota. We now serve 66 of Minnesota's 87 counties. We deliver treatment to over 38,000 annually, and we serve around 700 schools per year. A hallmark of Children's Dental Services that I inherited when I came on 24 years ago is that we are exceptionally diverse. Over 60% of our staff represent BIPOC communities and together speak 28 languages. Right now, around 80% of the patients we serve represent BIPOC communities. We're really grateful and honored to be in partnership with the Minnesota Department of Health, working on the state's basic screening survey. We did that in 2009, and we're again working on that now. It's been an interesting process because we were interrupted by COVID. So we had everything scheduled, did our first screening, were interrupted, and are now in the final stages of completing the project this fall. This is just to give you a little bit of an idea of who we are. We are located, our leadership is located mainly in the Twin Cities, but we have staff who live and work all across the state. Our dental director, Dr. Fuang Do, has been with us for more than 25 years. She's one of 2 employees who's been with Children's Dental Services longer than I. I'm showing you all other staff who tend to work regularly on our school-based programming. Larissa Peterson is a tribal liaison affiliated with Fond du Lac Nation, who's working closely in our school-based care this year. And Sadia Khan is our school-based program coordinator. I also have pictured Ariana Riles, our associate director. So I just thought I would kind of give you a little bit more of a nutshell about who we are. We're largely a hub and spoke program, but we do have bricks and mortar locations. And so these serve as referral sources for when we see kiddos who then need to be treated with in an environment with nitrous, et cetera. On the left is our portable care and specialty clinic. And on the right is our about to be unveiled main headquarters in Minneapolis. Little more about our portable care program. We deliver equipment in utility vans, again, all across the state. It's portable equipment that fits into suitcases and can be set up in almost any site. And we need like a den by den room and a water source nearby, but we set up in schools, Head Starts, places of worship, you name it, all kinds of locations. This just gives a sense of how we have grown over the past 23 years. And this is a bit about our statistics. So I mentioned this to you that a very diverse population is targeted and served by Children's Dental Services. We serve almost 100% low-income people. The majority are on medical assistance, but we also deliver around 10% annually of care. That's a sliding scale, reduced cost or free care. I mentioned that, a really important aspect of our program is delivering culturally competent care, which to us means more than language fluency, but also understanding cultural norms, religious needs, diets, traditional dentifrices, and translating all of that into a curriculum that guides our staff on how to deliver care in school-based and community-based settings. So what are the school-based services that we provide? We don't just do sealants. Dr. Phibbs was mentioning the need for follow-up resources. We provide a full range of preventive and restorative, or of the full basic range of preventive and restorative services on site in schools for a number of reasons. Unfortunately, there aren't a lot of referral sites, right? We always give patients the option if they have a place where they want to go. If they already have a dental home, after we do a screening or some school-based care, we encourage them to stay with their dental home. But sadly, a majority of Minnesota counties are dental professional shortage areas, and there's nowhere to refer. And we also find that when we do refer after providing preventive services, that only about 40% actually follow up on the referral for a lot of reasons, transportation, et cetera. So our philosophy is to do everything we possibly can in the school-based setting. So we do radiographs, prophylaxis, fluoride sealants, one-on-one education. We do restorative care, including exams, billings, extractions, and grounds. In 2022, we served over 29,000 students and over 40,000 sealants in Minnesota schools. I will say that, so we were an early adopter of telehealth. We were doing telehealth before we were getting reimbursed for it. Luckily now the sort of payment mechanisms have caught up. And I will say that one silver lining with the pandemic is that a lot of us are more used to telehealth. So, we obviously in the world of dentistry, you need to touch the child, you need to touch the patient. So it doesn't, of course, eliminate a face-to-face contact, but we think it reduces about one visit and makes it so that by the time we call in a restorative provider, they are very prepared to target the care directly to what the child needs. Right now, our hub for telehealth is the Twin Cities. However, I'll talk about this more in a little bit, but we have a new hub that's under construction now in Duluth, Minnesota, that will be the telehealth hub for all of Northeast Minnesota. What are our goals in school-based dental health? It's to, and I believe Dr. Phibbs probably covered a bit of this, so forgive me if I'm repeating, but to improve oral and overall health by expanding oral healthcare services directly on site in the school. And typically that's with that health office, but I sort of feel like if you've seen one school, you've seen one school. We've had schools who have set us up in the speech therapist office or the counseling office. We've had them put us in like a separate physical activity room on the stage. It could be in a variety of different places, but it is about integrating our services with what the school is delivering, decreasing multiple barriers that affect families with low incomes from accessing oral health care. It's right there on site. The parents don't have to miss work to bring the kids there. It's integrated with other supportive services, et cetera. And those include primary mental health, nutrition, student social services. We're often working with all of those providers on site in the school. I'll give you a little bit more information. I mentioned that we've been working with the state on the BSS. I'll just talk a little bit. What does that mean for us in terms of preparation? We have lead hygienists retained and trained. We have specific equipment purchased for that because our sealant, our basic screening survey is coupled with a body measurement BMI survey as well. We had been utilizing SEALS software, although we're reporting in a different way now. And there's also a randomized site selection component for that. Currently the sample size is 60 schools, 10 Sentinel schools, and 14 tribal schools with which we are working through the Great Lakes Intertribal Consortium. Dr. Phibbs is really involved in the sampling for that. And so far, we have screened over 1,500 students, and the goal, when it is done, there will be over 3,000 students screened. It's a parent guardian passive consent that we are working with through our BSS program. A little bit more about the Great Lakes Intertribal Epidemiology Center. They are an established public health authority supporting American Indian and Alaska Native communities to improve health. And we are working, there are 14 tribal schools across Minnesota. And so for this portion of the project, there isn't a random sample. All 14 of them will be served. I think one thing I want to highlight is that I think that it's fantastic that this has been identified by the tribal schools as a key need for them. So we're really thrilled that they're part of the partnership. I mentioned that we're doing oral health screening, growth screening, and student demographics as another component of the survey. Overall, this isn't, we have been asked from some schools, especially recently, like, what is the intervention here? Will our students be receiving fluoride, for example? And the answer is no, that's not part of it. There's no direct intervention that improves the health of the child on that very day, but the surveillance is incredibly important. And this is part of the message that we work on with the schools as we engage them in this project, and that our partners, the Department of Health, are really engaged in, is educating the schools that this is a really important endeavor for us to understand who is at risk, and then to be able to target resources and overall reduce caries experience in Minnesota children through the screening project. When we do that, we're hoping that we will ultimately be able to access preventive, restorative, and emergency health care. And I will say that, over time, we are seeing improvements in the underlying health of Minnesota third graders across the period of this study. Ultimately, the goal is that our state oral health program will have increased capacity and understanding for how to target services in the future. I mentioned, I'm going to now sort of like jump back into, new things that are happening specific to children's dental services. I mentioned our Duluth-based dental hub. This is actually a historic building that many of you, if you're going up the North Shore, may have driven by on Superior Street in downtown Duluth. It's from the late 1800s. That is a photo of it on the left from the early, it's from the days near its inception. And then this is to the right is what it looked like when we purchased it. And this is a rendering of what it will appear like when we have completed it. I think that this has been a really important collaborative effort between folks who are interested in city revitalization, bringing historic resources to underserved populations, and bringing many providers together under one roof. There will be a space for example, MNsure navigators and child and teen checkup providers, social workers, etc. And there will also be housing for the traveling workforce. A little bit more about that. I'll share these slides, but this is, if you Google, you can learn a little more about the project. This is one of my favorite slides because I think it shows a number of the innovations that we're integrating today and that I know many of you are as well. This is a slide of portable care being delivered in rural Minnesota, utilizing telehealth modalities with an unlicensed dental assistant who's bilingual and an advanced dental therapist using a therapy dog. I think that that's a lot of innovations that you can get into one setting. And I think that these are a lot, this particular photo took place in the Redwood Falls School District. So our schools are thrilled to host all of those innovations, and they really make a difference in improving access to care to our children and families in those regions. That is the sort of like overall nutshell of our program and the current work that we're doing in Minnesota. And I'm happy to take any questions from you.
And did anyone have any questions for Sarah? I just have one question. Sarah, thank you so much for sharing all your information. You truly are an inspiration for me and for my community. I love what you're doing. I love how you're growing, and I wish I could learn more and more and more from you so that I can implement that in my community. So thank you for presenting today.
Thank you. And unfortunately, I can't say. Wait, would you tell me your name and where you're from?
I'm sorry. This is Holly Jorgensen. I'm from Let's Smile in Guatemala.
Oh, I know you. Hi, Holly.
I'm sorry.
No, that's okay. It's like I feel a little like the Wizard of Oz. I'm looking at a screen and you all can see me, but I can't see you. Thank you, Holly. Great to hear your voice.
So,
And did anyone else have any questions or comments? All right, awesome. And Sarah, thank you so much again for being here with us. I really appreciate you providing us with all of this information. And I think for a lot of people who are looking to also start programs, this will be really great for them to see. Would you mind if I shared this with everybody, your presentation?
No, I'm absolutely happy to. And, I was listening to Dr. Phibbs' presentation, and I'm really happy to speak with anybody about what we're experiencing now in terms of interfacing with schools. One thing I'll say about the BSS that's been educational is that it's been much harder since the pandemic to interface with schools around that. That's really, that was like an unplanned way for us to see like pre and post pandemic how it is to connect with schools. It was much easier to schedule schools for the BSS before we knew we were coming into a pandemic. Afterwards, it's been difficult. They've been really taxed. And I think, thank you, MDH and Dr. Phibbs, for bringing that to the surface. I think it really deserves community conversation about how, with all of the just the heavy workloads on our nurses, how do we bring dental care back to the fore? We know they need it, but how do we carve out time? And who is the person? It was interesting to hear also Dr. Phibbs say, it could be your school nurse. Sometimes for us, it's the receptionist. Sometimes it's the vice principal. In super engaged schools, it might be the principal. I sort of feel like you see one school and you see one school, right? They all have their own way of engaging. But I'm happy to share what we've experienced, and I'm happy to be part of a continuing conversation on that.
And did you have any questions, Prashida?
No, I just wanted to thank Sarah. Sarah, this is Prashida. I know you can't see me. Are you able to hear me?
I hear you, and I know it's you, Prashida.
We talk so much for our BSS, and we really appreciate you for standing by us to do the survey. And I know how difficult it has been, both for CDS and MDH to get that buy-in from the school, especially after pandemic. So thank you for helping us collect the baseline information.
I'm sorry, was there a question?
No, I just wanted to thank you for helping us collect the baseline information, because without this survey, we wouldn't even know the baseline for sealant. So that's why it's very critical. And thank you for also volunteering to speak with our broader audience about the challenges that we are facing with the school. I feel like that's a very important conversation. So just wanted to thank you for our partnership.
Oh, likewise. Thank you so much. We have such a fantastic oral health program in Minnesota. We're really, really fortunate. So thanks for including me today, and thanks for accommodating my croaky voice. And
we hope you feel better. Thank you.
Thank you so much.
I have your presentation up. Would you want us to put it up and then we can click along, or how would you? That'd be great. Perfect.
It's on my email.
I sent it to you.
Yeah. So I just need to. How do you get them? No, how do you get rid of them?
Actually, yeah, let's pause Y'all want to take like a quick little 5-minute break if anyone has to go to the bathroom? Then let's take a break right now and then we'll come back to it.
Yeah, like that.
Go check and see if I've seen
Okay, I'm unmuted. Okay, I think we are getting ready to start. This one?
Yeah. I'm just using it as a microphone. It's easier.
Okay.
It'll go directly to Zoom.
And I don't know how you figured that out. It was
Me?
cool. Yeah.
I honestly, things have been breaking on me so much at MDH that I just started figuring it out myself. Because calling, like they told me basically every solution I could ever do. So 870-866.
Why am I not able to see
The
this?
food is here way too early.
Way too early, right? Yeah, I know. Okay, yeah, because I don't have control there. So Julie's there. So I have to use your computer to advance the slides.
Yeah,
I think.
if you wanted
Yeah.
to share it on yours, I sent it, but otherwise you can just use mine.
Yeah,
Whatever's
I can just do it from here and I can keep this for the
Thank you.
go and declare. Okay, just get it straight. So, and then do you want to get it started and then you can take over? Yeah, are you able to hear me? Okay. Is it okay now?
Yes.
I turned it off.
So we can hear me. Yeah. Because, yeah, sorry. All right, here's this. And then if you want, we'll just like click through the slides when you're ready.
Yep, that sounds good. Thank you. All right, I guess this is my microphone. So, well, thanks. Yeah, thanks. Thank you for, oh, you are getting a call.
Oh my God, are you serious?
That's okay. Do you want me to? I don't know.
Maybe
I'm
just
just
try.
texting her.
It's,
What would be,
I
because
just ignore it if you're getting a call. It's not a problem, but
I'm
just
like,
wanted to
we
make
can
sure
do
I
that,
can do
but
anything.
Nancy knows what we're doing.
Okay.
So you can go ahead and start.
Okay, great. Well, thank you very much for inviting me to share. I love talking about Care Clinic, and so I always love to have an opportunity to do that. I do just want to kind of echo all that we've learned so far. Today, my son just graduated with a bachelor's degree in biology, and he got hired on as a school nurse. I'm like, is this legal? Can you do this? And so it must have been kind of one of those aids that they're kind of talking about. Luckily, he did work at our clinic for a summer as an AmeriCorps Vista and then volunteered at a clinic this last year. So he has some experience, but he's only been in this job for a couple of weeks. And last night he called me and said he saw 45 kids in the school district, the Robbinsdale School District, just yesterday. So just that load that those school nurses have is really remarkable. So I love to hear from all of you, your ideas of how you're working with schools, because we're kind of new at this. And so I liked the last presenters just guidance that if you work with one school, you've only worked with one school, because it does seem like that's really true. And we have to be creative in how we're working with the schools. So again, my name is Julie Mallion. I'm a registered nurse and the executive director of Care Clinic, which is an integrated clinic in Red Wing, Minnesota. So we're a rural area. Just wanted to start by sharing a little history of the clinic. In post Hurricane Katrina, we had a group of health professionals from Red Wing that went down to the Hurricane Katrina site and set up kind of free clinics in church basements. And we're having dinner afterwards one day and thought, we've traveled all this way to provide this care for people, I bet there's a local need just right in our own community for services like this. And so they came back to Red Wing and just started gathering, inviting other people to the table. It was a really grassroots effort. And Claire Larkin, I think who everyone seems to know in the dental world, is from Red Wing. And we were lucky to have her be one of those people that was joined at that grassroots table level to try to figure out, you know, is there a need in our community for kind of an integrated free clinic? And if there is, can we make it happen? And I got invited because the small community, the first thing they were going to do was go out to other free clinics and learn from them, learn their models, try not to reinvent the wheel. And so they knew there was this free clinic in Menominee, Wisconsin, and somebody on the committee knew that I was from there. So they called up and said, do you happen to know anyone associated with the free clinic in Menominee? And my dad was actually the founder of it, and he was the medical director and the board chair at the time. So I said, I do. And so let me set up a meeting with him, and then can I join and be kind of a part of this group? And so that has really been kind of the history of my experience with this organization. Is like, I'm the director, but I always feel like there's this like higher power, this higher director that's kind of making sure that people in our community who need access to affordable care are getting it. And so I was very glad to be invited to the table. So the next slide, I think, has our mission. We established, our mission is really our name. So CARE stands for Community Access, Resources, and Education. And then the next slide shows kind of all of our services. And when the grassroots group kind of started, dental was at the table right from the start. But interestingly, Claire, I don't know if you want to share any memories of this, but 15 years ago, that was kind of when this new collaborative practice and the dental therapy was coming into play. And it was kind of interesting. I don't know if you remember, but there was, Claire is such a wonderful advocate for the innovations in dental and providing access to rural care. So she brought this forward as an idea of this is how we can help provide, affordable access to dental care in our community. And the dentists at that time just were not very supportive of it. They were wanting to kind of protect their area. And so for multiple reasons, we decided to open a clinic and not include that initially. We wanted to start small and then kind of expand our services. So currently these are our medical our services that we have: medical, dental, mental health, prescription assistance. We have a medical legal clinic, resource connection. We try to be a resource hub, and MNsure navigation. But the next slide kind of shows our growth of kind of how we brought those different services in. So you can see there was a lot of momentum around this from our first meeting that we had kind of as a grassroots committee until when the clinic opened in 2010. And I think that must have fallen off the slide somehow, the 2010. But it was like a year until we opened, but we decided to open just as a medical clinic, providing free medications. And then we wanted to be a resource hub to know all the other services, those upstream measures that could kind of help people improve their health and connect people to those resources. Maybe if you can go back to the other slide of just our growth, the bar chart. But I say that we had kind of some pushback on the dental because that changed over time. So about a year and a half after we opened, we did open a dental clinic, and we decided to just open it to deal with the most critical needs. So an extraction clinic. We had a dentist who was kind of a champion of this and recruited other dentists. So we actually were fortunate to have 12 dentists who would come in they would take turns on a weekly basis. They'd volunteer once a month, come in on Tuesday evenings, and it was pretty much all volunteer run. So we had an integrated clinic, walk-in clinic, Tuesdays from 4 to 8. We've been doing that for the last 14 years, and added dental about a year into it. And I mean, it was pretty amazing to hear the stories from people and their need. For our medical services, we served only uninsured people that were 275% of poverty level or below. But then, of course, we all know the challenges of people who have Minnesota healthcare program insurance too, and knew that that was a need. So for our dental services, we included those patients. And I remember one of our very first patients who came in, he had medical assistance. He had been approved for having heart surgery, open heart surgery, but he needed to have a dental infection dealt with before he was allowed to have that surgery. And he could not find anywhere that would see him and take care of that dental infection. So his surgery was getting pushed out, and I mean, his life was being threatened. And so he was so excited when he found us, and we were able to do those extractions and things that he needed. I also remember we had one of our first patients was a farmer who had an abscess and had been taking his cattle's medication, which we know how huge those are. And I mean, how do you figure out what dose you need of an antibiotic that's meant for a huge, animal? And then I also remember a single mom, she was probably like in her 30s, and she came up to me after she had had her extractions, and she just expressed her thanks. She said, this is more than just dealing with my oral health. She said, this is my sobriety. I, have had a meth addiction. I have overcome that over the last 2 years, but my sobriety is at risk when I, get into situations where I have dental pain, and it's just such a temptation to start using again. So she just really thanked us that it just really helped, overall her life and health. So as you can see, for like 9 years, we just provided that dental extraction clinic, and it did a lot of good work, but we always dreamed about doing more in that area of dental health. So we moved to a new location about 5 years ago, and we were planning that we were going to try to expand in kind of this additional space we had into preventive and restorative care. But kind of before we had a chance to really put our plans together like that, we were approached by the schools and asked for help, because all of our schools in our county had never had a dental screening program, dental health program come into the schools before. But Children's Dental Health had come in for the first time to our Red Wing Public Schools, which was wonderful to have that service for our school kids. But they identified 60 kids that had like critical, urgent dental needs. And they have a referral clinic down in Rochester, but kind of as we've heard on the previous presentations, that's really challenging for a lot of families, to get off of work, and it's about an hour drive. And just to figure that all out. So the school nurses, though, were amazing. They were so committed. We actually have that school nurse that I worked with on this project on our board right now, just because I know how deeply she cares about this. They tried to get those families connected with care in Rochester, but it just wasn't possible for a lot of the families. And so they reached out to us and said, could you take care of these 60 kids we can't get care with? And I'm like, I just started having a conversation with an advanced dental therapist about maybe bringing her on. But I was like, these are urgent needs. So let's get going on this. And so we kind of, rushed our process along, brought on an ADT, and the schools actually were so committed to this. They were like transporting the kids up to care clinics so that we could get those dental needs met. Of course, that was right before the pandemic hit. So we just had brought on all of these paid staff. Up to this point, we had been primarily operating with volunteers at care clinic, but we were bringing on all these paid staff. It was a little challenging to do that just as the pandemic hit. But I should say, I meant to say before that, all of these dentists who had been volunteering, these 12 dentists who had been kind of opposed to having the ADTs, having collaborative practice, after seeing that unmet need in our community for those 9 years, when we approached them and said, there's 60 kids who need this care. Are you supportive? Because we didn't want to have our volunteer dentists leave because we were bringing on an advanced dental therapist and probably paying that person and not paying them as volunteer dentists. But every single one of them, you know, after seeing that unmet need in our community was like, yes, move forward with this expansion, hire an advanced dental therapist, will continue to, you know, come volunteering. We see the need and we want to kind of support that need. So unfortunately then the pandemic hit and a lot of those dentists said, you know, like my whole office staff is dependent on me being healthy and being able to provide like salaries for everyone. And then there was kind of the shutdown for all of the dental clinics. And so we, during the pandemic, kind of lost a lot of our dentist volunteers. And we kind of shut down that extraction clinic and then really just focused on our advanced dental therapists, dental hygienists, assistants at Care Clinic. And it was really good that we were open during that time though, because as I think we all know, dental offices were closed down and then they were only supposed to care for their dental home patients who had emergencies. And so we had so many people calling us with these dental emergencies who didn't have a dental home and they didn't have anywhere to go. So I think within that like month when it was really shut down, we had 4 different people that came to us with like life-threatening abscesses, like their airway was about to close off. And we fortunately kind of with our integrated services, we were able to enroll them on health insurance, send them to the emergency room. So their emergency room was going to be, visit was going to be covered so that abscess could be drained, or I think one of them was even hospitalized for a while from the dental infection that they had, and then come back to us to actually fix the problem that they were having. So, so even though it was challenging timing to be like expanding our dental clinic at this time, it ended up being very good timing for a number of people in our community that we were there for them kind of during that dental shutdown. So it's been really amazing to see the growth of the clinic. The next slide does show when we kind of decided to expand in 2018. I kind of pride, like we're from Goodhue County and we have 3 Mayo Clinic medical centers in our county. And I think of us as being like a really healthy county with good access to care. But I was surprised at this oral health data report that had Goodhue County tied for the 4th worst county in all of Minnesota, the 87 counties in Minnesota, for providing dental access, like at least 1 dental visit to people on Medicaid. And so like, you know, we can do better. And then that definitely showed that there is this need for a critical access dental clinic in Red Wing. So we kind of saw those kids, but then we're like, we need to like take a step back and really make sure that we're putting this clinic together in the appropriate way. So we hired Claire Larkin to be our kind of coordinator and to get all of the pieces in place. And if you know Claire, you know she's very detail oriented and was going to make sure all of those pieces were in place. Claire, do you want to share anything about that time of kind of establishing us as a critical access dental clinic?
Thank you. It was about, what was it, a month or so before I was to be retiring that we met at the, oh shoot, I've just lost her name, the woman that wrote the teeth book. We were at that, Mary Otto's, that's embarrassing, I should know her name. And Julie explained that, and we were at the same meeting, and Julie said that this was their vision, is to start being compensated for care rather than trying to fit all the pieces together for the volunteerism. So I thought I knew about the Minnesota Department of Human Services hoops that my collaborative dental hygienists have had to step through to do this, but wow, it was a huge learning curve for me as well. And Julie's staff just stepped to the plate that whatever you need, and yes, we'll pull this all together. And I think that was the key, and great leadership too. So I'm passing it back to Julie.
Well, we are so grateful that Claire came on as our consultant and helped us through all that. Because as I said, I'm a registered nurse and I've even like had to learn this nonprofit management kind of on the job. And so to then also try to be learning dental, it was kind of a challenge. And then as you can see too, for children, we were a little bit better, but we were still like ranked 73rd out of 87 counties for that. The next slide, I think it looks like this report is going to come out every 2 years. So in 2020, I think that's the next slide. It shows that we have improved our ranking quite a bit. So now we're 45th instead of tied for the 4th worst out of 87 counties. But it's kind of disheartening to see that really that access only went up by like 2.2%. So it was like 26% in 2018 and 28.2% in 2020. And so really what's that showing is across the state, there's been a decrease in dental access. We have had a slight increase, but hopefully we can, when the 2022 numbers will come out, and as we expand, that we'll just see our ranking and the percentage of MA patients that have access to dental care just increasing. So next slide. So for a couple of years, we provided dental care just at our site at Care Clinic. We're in a Mayo Clinic building. But then we wanted to do more to make access even, greater for our community. And a lot of the schools around us didn't have, I think Red Wing was the only one that had a school program for dental services. So we reached out actually for like the last 8 years. I think I've gone every fall to the school nurse meeting. So there's like 28 school nurses from our county that all get together to kind of get organized, share information. And they're very generous to give us like an hour of their time at these meetings before the school year starts. And I would always ask, like, what's your greatest needs? And dental was always kind of way at the top. And so we always wanted to do more to be able to try to help those school nurses. So we have not had a problem with buy-in from the school nurses at all. They're like really asking for help in this area. But we, again, wanted to kind of start small and grow. And so we started with Cannon Falls schools, and then added Goodhue and Lake City. And now this year, even though we had a great partnership with Children's Dental Health Services over the years of working together since we kind of expanded our clinic, I think the school just decided it's a little easier for people, for the students just to come to us as their dental home. And so we're going to be going into the Red Wing Public Schools as well. Although this does create a challenge for us, because when you take patients on and say, oh, we'll be your dental home, that is committing that you're going to have enough appointments that you can do all of their cleanings and provide all the restorative work and urgent work that they need. So we're in the midst right now of planning kind of a big dental expansion. We're trying to hire staff right now. We also have I don't know if you're all aware of the pipeline program, but we provide college tuition through this grant that we get through the state. And so we're kind of trying to create our own dental professionals. So we have students right now who are going to school for dental assisting, dental hygiene, dental therapy. So 10 of our employees are students, and then we pay $6,000 of their tuition and give them on-the-job training. And then we're hoping that they're going to stay with us. But we have one of our employees is a dental therapy student that will be graduating this spring. So kind of our goal is to get a dentist at least part-time on staff so that we can kind of be that dental therapy training ground for him to be able to stay with us kind of long-term. But there's a lot of need out there, and I know you all are probably aware of the shortages in the field. So really trying to recruit people who have a passion for doing this work in public health and providing access to dental. So if any of you have any ideas of someone who's looking for a clinic like ours to use their skills, we would love to have those connections. I honestly can't remember what the next slide is, but yeah.
Just for those of you who have been involved with dental professional education, just want to emphasize though that the on-the-job training has to be in concert with those students being enrolled in a education programs.
Yes.
It's just such a hot button to think about people being trained on the job per se, but it's not only that. So
Correct. Yes. Yes. Oh, I guess this is just bragging a little bit about our staff, our clinic. I think the one I'm most proud of, this is our patient satisfaction survey from last year. Number 7, clinic personnel were respectful and caring. 100% of it was 112 patients who answered the survey said that care clinic personnel were respectful and caring. Even just that patients say they received assistance identifying ways to improve health, 99%, that their health improved as a result of coming, 96%. So a lifestyle change was made, 95% said that was true. So we really are trying to be kind of an integrated clinic, look at the whole health, provide that medical, mental health. We're also really committed to having our staff mirror our patients. So about half of our employees are from the Hispanic community. We serve a large the immigrant population in our community, and our Spanish speaking. So that's been really helpful in providing good care for our community. And then we really do try to provide a value to not only like a financial value too, that we try to be wise with the resources that we're given. So every dollar donated to us, we turn into $2.50 of healthcare services. We still rely a lot on volunteers, and some of our volunteer dentists did come back and are doing the extraction clinic like once a month at Care Clinic. Yes.
What formula did you use to know that for every dollar donated, it was $2.50?
Yeah, I could share our kind of calculation with you, but we get like the list, because this is not only for dental, this would be for all of our services. So we get like the list of what level 1, 2, 3 visit costs, and then compare it to what our overall costs have been, cash costs, and a variety of different things. But yeah, we really do try to be that integrated clinic too. I know a lot of people come up, have anxiety around dental visits. And so sometimes our therapists have gone in and done like breathing exercises or relaxation exercises with our dental patients before they go in. Although one of them said, no way, I'm like terrified of the dentist, and she was a mental health therapist too, but so it's real, right? And same thing with like when our dental patient gets in the chair and you take their blood pressure and it's too high, then they can go and see a doctor or a nurse practitioner and work to get that blood pressure lower, so then they can come back and have that dental visit. So last year, one of our dental patients nominated us for the DHS Commissioner Circle of Excellence Award. And so that was just really meaningful, yes, that a patient would have taken the time to nominate us for this award. And he actually was willing to speak at it, at the little award ceremony that we had. And he was kind of funny. He said, you know, that the staff was so good at following up, especially he was a dental patient and MNsure client. But he was like, the staff is kind of borderline harassment. They're like calling me up all the time, trying to get me in for my dental appointment. But he said, it's a good level of harassment because rarely do people love to go to the dentist, right? And so you kind of really need staff that are committed to doing that follow-up and trying to get people in. I will say though that our dental staff is amazing, especially our dental hygienist is wonderful with kids. A lot of the kids that we see, this is their first interaction ever going to a dental office or seeing somebody in the schools, and they like love to come to our dental office. I hear them all the time, when can I come back? I love coming to the dental office. So that's a big part of just, I think, the spirit that we're trying to create in that work environment. So next slide. Just, yes, takes many hands. I had kind of heard before I was kind of getting into this dental area that sometimes there's kind of like turf wars about different things. So I love to see all of us together, sharing knowledge, not feeling that way, being like, how can we help each other? There's plenty of work to go around, right? So how can we all help to make each other better? And how can we partner together and not feel like we're competing against each other? Because we all have the same goals. And so I thank each one of you for your passion. I loved hearing from some of you at the last meeting about the work that you're doing. And if you have any ideas of how we can partner together, let me know, or any, like I said, any people that might be looking for a job, we'd love to have them. We're also looking like just a big kind of capital campaign to build a bigger space for us to be serving patients. So any questions that you have? I see your lunch has arrived too.
Oh, no, we can still do questions.
Okay. Yeah.
For you and for the initiative and just being an oral health advocate. I mean, kudos to you and your team, and with Claire's leadership and with you reached out to the right person, obviously. I don't have any questions. I'm just very, very proud of what you've done for your community.
Oh, well, thank you very much.
Yeah.
all of you.
Yeah, it's great. Well, thank you so much for letting me share. And yes, I'm happy to be a part of this group. And thank you, Claire. Yeah, sure. All right.
And then I just wanted to say, part of the reason I thought it would be really great to have Julie present is this was such a unique thing that I hadn't seen, is somebody who's a nurse starting something like this in a place that's a medical clinic, you know, being like, there's an issue here and we need to solve it. And I think that can be, you know, really difficult to start, especially when it's not your field. My mom's a nurse, so I know she's, but I just want to say thank you so much. Here, let's put the first slide on, since that's your care clinic slide.
I also have to share mission in Congo, in DR Congo. And last week we brought dental services. We don't have dental services there. And so unfortunately I couldn't go to this training, but my dad was there. And they brought this team to train 20 Congolese, just people from the community. They did a 4-day training to how to extract. On the back, to the rural communities, yes. And so it's pretty amazing. They've done this like all over the world, this organization. But so I can't imagine like having an extraction done from someone who's had 4 days of training, but there were so many people who wanted that service that people showed up to be the first one, you know, to have that tooth extracted with the students when they were just learning how to do this. So there's this big crowd of people waiting there for extractions, and a green mamba snake came. And I was between all of these people waiting to have their extractions. So it's like a mass exodus, but apparently some teenage kids came and like snatched the snake over the head. But anyways, I just say that because we have so many challenges here, but it's also good to be reminded how blessed we are here with the services that we have. And yes, so we don't have to be trained in 4 days to do extraction. So, yeah. I did have someone, there's this woman there's a dentist who had a family emergency last minute and couldn't come to our extraction clinic. So I had to go tell the patient. And this one woman was like, give me a pliers and going. Oh, yeah. Oh, it was awful. But anyways.
So I feel like dental pain is a different kind of hurt.
Yeah.
Like you only have so many, well, you have so many nerves. It's like if your arm hurts, it kind of gets everywhere. But with your teeth, it's just and then your brain hurts, and it's because and it also raises your blood pressure because you're stressed.
Yeah.
And so then you go in for your extraction. We had a patient, it was the first time that I was like, you know, if this man hits me, I'm scared, but I almost like understood because he'd been having the pain in an abscess for the past week. And so this was his first time actually being able to get into our clinic, and he had waited so long at our walk-in clinic only to be told his blood pressure was too high.
Okay, and couldn't get the extraction. Couldn't get the extraction.
Yeah. So I think they might have prescribed him some medication, but he was mad. And yeah.
And at the school nurses conference last year, I was at the table and I had all the GK model on my table. And I also had, so I had like progression of to GK model. And one of the nurses stopped by and she said, oh, if kids are lucky, they'll come to me like this. And it was a stage where a kid would already have grossly decayed tooth or like an abscess. And I'm thinking about prevention and all these things. And frequently at the conference, multiple nurses stopped by my table and they were pointing out to the, you know, the model. And then they said that's the time when they come to the nurses. So it's not even like by the time they go to the nurse's office, it's already too late. So I will pass it on to Antigla, and then should we do a picture in lunch or how do
Yeah,
you
we
want
can
to
start
do it?
with a picture.
Yeah, let's do picture. I wanted that in the, but I don't think it's important. Let's do a picture.
Yeah. Well, this thing still has life in it. Yeah, let me know when you're ready to start.
So we can do a group picture and then have lunch.
Yeah, that would be
Do you want to take a
great.
picture there?
Yeah, I think it'd be nice to do it with that banner. Yeah. Let me.
You can take our picture and then I will take his picture with you guys.